But what's emerging in Wales? Well, what have we got? We've got a political pledge. I don't know if anyone here voted Labour. I voted Labour. I didn't realise they'd done this, though. This is in the manifesto. To review access to psychological therapies. It's better than saying nothing, isn't it? Actually, I think it's quite meaningful. Something might come of this. They obviously will be concerned not to make financial commitments. And the health budget in Wales is not safeguarded in quite the way it has been in England. But there it is. So that's in the manifesto. There's a legal requirement to have a primary mental health care workforce. I'll be talking more in depth about that shortly, about how that interfaces with IAPT agendas. But that's actually a very important component. We've got an access target, which we forgot about in 2006-2007, what was called a SAF in those days. So this was a 12-week access target. We're supposed to have people who are in secondary care, they're supposed to have just 12 weeks between referral and actually beginning treatment. The 2006-07 SAF period, we sort of plodded through it, and nobody in the whole of Wales, I think, was truly able to deliver on that. Or if they were, it was because there's some other explanation, like very few people were getting referred to the service in the first place, sort of thing. And then the SAF target, it's still out there, it's still on the books, so we need to recover it. It's even better than Scotland, isn't it? But it's got hidden because of the complexity of the task in trying to deliver on accessibility there. There is a draft whole system policy guidance which is happening. This is what the IAPT group has been very focused on. Matters have been slowed down in the last 18 months, in part because of the cull, I think, if that's not too strong a word, of Welsh Assembly civil servants. There's intelligent targets in Wales now. These are actually These are important insofar as actually the chief executives have to get anxious about them in the local health boards. There's an intelligent target about depression. Are you aware? Is this very familiar? No? Okay, so the idea is that everybody who is in a secondary care hospital setting, ultimately, but at this point, people who have long-term conditions, diabetes, ischemic heart disease, strokes, will be screened for depression using the PHQ-9, which is the same instrument that GPs use for their QOF, and the one which is used in the IAPT program. Having been screened, you find out you're depressed, you might say, well, then what? And there's a lot of people in Wales saying, then what? But at least we're starting, I guess. And that has to be in place over the next year. There's also intelligent targets over other clinical areas such as eating disorders and dementia. It's a start. And frustration I put on the bottom of that. There's a lot of that, isn't there? And quite rightly so. About what's emerging in Wales. I don't know if any of you were here at we had a meeting in February, I think, in Cardiff. And there's quite a lot of heat in the room, I think. So I'm just going to pick up some of those things which are on that slide there. I missed Barbara's presentation this morning, so forgive me if I'm repeating things that you've just heard, but maybe it's also linked to this IAPT thing. Part 1 of the measure has describes, in a sense, a job for the primary mental health care worker. And that job, I think, is a very big job and has 5 functions to it. It's likely to have 5 functions to it when the model behind the the national model for primary mental health care is finally settled. Maybe this is what Barbara was talking about, I guess, isn't it? Was it?
You didn't go into much detail about the model.
Okay, maybe because it's still in draft, so I will say this is in draft, okay? But actually, what it's saying is, if you're a primary mental health care worker in Wales, you are supposed to be good at mental health assessments. You're supposed to be a source of expertise and advice and guidance for your GP, because you're going to be linked to general practices. You are supposed to be able to be a source of advice and signposting, dreadful word, for people who come and see you. And you are supposed to be the point in a stepped care, a referrer into a stepped care system. So whether that means you actually gatekeep, or whether you're just an important person involved in the upward flow of mental health problems into secondary care, hasn't yet been resolved. But you are part of that. And then finally, and this is the important bit from our point of view, I think, you are supposed to be somebody who can deliver on therapeutic interventions of sorts. And there's an indicative list in the early drafts of what those therapeutic interventions might be, most of which hover around CBT. I don't think that's the important feature of it. I think the important feature of it is that it's suggesting that the contact length for somebody in this job will be somewhere between 6 and 10 meetings. If it's if you're involved in treatment as opposed to just assessment. I think if you were coming down from the planet Zog and saying, here's the Joneses next door in England with their brand new spanking IAPT model, and here in Wales, what's happening here? You would compare these two things and say, well, actually, this IAPT, the part one of the measure, that workforce is sort of comparable to the primary care reforms that are going on in England. If you remember that the primary care reforms in England through IAPT have got a low intensity and a high intensity division. It looks as though we're not going for that in Wales. It looks as though we're sort of pitching between, sort of intermediate skill sets. So we have to sort of think, well, actually, what should those be? In the measures in the draft model, there's also reference to quality standards. By quality standards, we mean things like the need for assist service to be accessible, deliver on an appropriate range of evidence-based options, and be outcome-focused. All of these sort of buzzwords, isn't it? These are quality standards which have been derived from a national audit, the National Audit for Psychological Therapies, which has got the data, but hasn't yet reported on it. That will come out in the autumn of this year. It was a national audit of all psychological therapies in the UK. It involved Wales. And they developed audit standards which I think could be used usefully to help design services in Wales itself, both at a primary care level and at a secondary care level, because you've got measurable standards. You either have managed it or you haven't. The model, the measure, as Barbara I'm sure told you this morning, is supposed to be in place by August of next year. Well, actually, the legal requirement's later than that, isn't it? But the ambition is to have something in the summer of 2012. These are some of my worries. And the worries are, I guess, around the workforce planning mechanism. It's not yet clear. It's not sorted out, essentially, so it's not that it won't be clear, but it's not yet clear. So, for example, the numbers aren't based on access models of unmet demand. What that means is that when Lord Layard turned up with his report and put it on Gordon Brown's desk, he calculated or set off a set of calculations which tried to make sense of how much unmet need there is out there for people with common mental health problems, how many of those people would then present to a GP? How many of those presenting to a GP will be noticed by the GP? How many of them being noticed by the GP will be then thought, oh, you better be treated, and then put into a psychological therapist service? The model isn't based on anything like that. The model has a figure of about 1 per 20,000, one primary mental health care worker per 20,000 population in Wales, is the sort of benchmark, which is what's being anticipated would be the workforce. My hunch is that will turn out to be what we've pretty much got. And it doesn't, as I say, it doesn't, it's not based on an access target. The access target that the English IAPT programme has got is 2 weeks to assessment and a further 2 weeks to treatment. So 4 weeks to treatment. So if you've got the first calculation that I mentioned, and you've got that access target that I just mentioned, then you end up with a number of how many people you'll need to meet this demand and how many sessions they ought to give and do. So you end up with this sort of industrial design with a figure which is still quoted in the 2011 Department of Health, which is about 40 people per 250,000 population. Of those 40, 15 should be high-intensity therapists and 25 should be low-intensity therapists. And if you have that, then maybe you'll meet the need, you'll meet the demand. Now, how does that compare to Wales? Well, I work up in North Wales. We've got a population in the Betsy Cadwaladr Trust, including the North Powys, of about 740,000 people. And the primary mental health care worker force, group force, is 40. So in other words, this is a very crude comparison, isn't it? But what we're saying here, I guess, is that the English investment is delivering maybe 2 to 3 times as many practitioners as we have currently. But the training plans and integration into the current workforce, that is going to be a huge task because, again, up in North Wales, there are people who are health board employed primary care counsellors, and there are people who are nurses and social workers working in what would be called the first access service. There's a lot of different diverse professions entering this primary care setup, if you like. And we've got to sort of somehow or other move from here to there so that we end up with what the model is suggesting in terms of part 1 of the measure.